So this is basically aimed for the local people, and I will have my bifurcation PCI talk on steps: definition, approach, strategy, technique, and then just give quickly three examples to demonstrate them. So everyone knows what the Medina classification is. Important thing is to make sure that you know what the angles are. So angle B is what is important. Occasionally we talk about angle A. This is the angle when we talk about 70 degrees or 90 degrees, and then the angle C is the Medina classification. Everyone knows, and this is there are three main things that you need to know about the approach to bifurcation PCI. One is the variation in anatomy. So clearly the angle of the side branch, how much plaque there is, whether it's left main or non-left main. Then the second thing is the dynamic changes during PCI. These are things that will change your strategy or your approach. So plaque shift and dissections. And number three, most important, whether you are in an ACS situation or the non-ACS situation. In an ACS situation, if side branch is the culprit, then it usually will need a stent. So you cannot usually do a provisional if the side branch is the culprit. In a non-ACS situation, the side branch is treated according to factors that I have outlined previously, which is the angle, size, etc. So the strategy, if it's not a true bifurcation, a focal lesion, sideline expendable, etc., you can do provisional. In a true bifurcation, suitable for stenting, you can do all these, which I'm not going to go through, all the techniques, the two stents. The algorithm again is very simple, despite all the Europeans and everyone telling it's very simple. If the side branch needs to be preserved, yes, then the likelihood of side is high, then you go for two stent strategy, whether you go for the two stents, whether it's T stenting or collot or reverse crush, depends on the angle. If the side branch is not important or etc., then you can go for provisional. The side branch compromise, if it does happen during an angioplasty, then depending on the angulation, you go for T or collot or DK crush. If it's a successful angioplasty, then obviously TB3 flow in the side branch, less than 70% stenosis, then the provisional has been shown to be a better strategy. Again, when we talk about two stent strategy, I divide it into three things. A short left main, you can do V stenting. That's probably the best. If the angle is 90 degree, you can do a T stenting. And if it's less than 90 degrees, 60, 70 degrees, then I normally do a DK crush, but you can do mini crush and collot. Now, what I want to tell you about is that the stents are different. Nowadays, they are similar, but not exactly the same. So we've used all these stents, and you can see that they are the same diameter stents are different designs. Now, if you are doing provisional strategy and you cross the wire proximally and do a kissing balloon, there is a poor scaffolding after the kissing in the side branch, as you can see with these two arrows, and this one part is slightly up. Now, if you do a distal in provisional, you do distal wire crossing and then do a kissing, you can partially stent the ostium of the scaffolding goes down into the. So this is important. In provisional, go distal when you are doing a kissing balloon inflation. Now, in final kissing balloon inflations, if you do no kiss, this is again a bench test, very authentic, despite whatever the data says. If you do one step kiss, you still have some struts in between. This is looking from the side branch. And if you do two-step kiss, which is what DK crush is, your lumen is round and it's much more visible. And then the re-stenosis and late loss has been also, Yakita Higachi had shown in a paper that there is a significant difference. The stent designs matter. Look at this Texas versus Texas. If you use two Texas, look at the amount of metal. And if you use two Zynes, the metal is so. Again, you combining stents, you need to be aware that what gives you the angiographic good result, and the IVUS now also is different. Again, stent designs are not all the same, and the technique. If you use collot for Nabori, look at the stent, how it's covering the thing. But if you use a Liberté, if you had used a Liberté, look at the amount of disruption there is in a two stent strategy with a mini crush. So it doesn't matter. The stent designs and the techniques do matter. Again, the balloons that you use for final kissing also do matter. So if you use non appropriate balloons, you can have these kind of stent disruptions or areas where it's not fully expanded. The same bench test using a 4 by 4 appropriate size, you can see the stents much better. Everyone knows about the Finney law, that how you size for the stents. Again, the time of inflation do matter, although we are very quick nowadays, 10 seconds screen. But look at this. This is a 16 atmosphere, 15-second timing, 15-second duration. And look at, if you increase this duration to more than 30 seconds, the scaffolding is much better. Look at the side branch scaffolding by the red arrow. And this is the same, in the same, exactly same stent bench test. So this in vivo, it's maybe different, but still this just gives us the mechanism of how duration matters. Kiss or not kiss, despite everything, final kissing balloon does have a difference in death and Q wave MI. Now, this everyone knows. The minimal stent area is related, is a predictor of ISR as well as outcomes, and 5, 6, 7, 8 is the usual formula. 5 for the left circumflex ostium, 6 for the ostial LAD, 7 for the confluence, and 8 for the left main. Anything above is fine, but anything below will give you a poor outcome. Outcomes in upper left main still in single digits for TVR and midterm death. So I think this concept about left main, everything should be treated with PCI if it's possible, and the mortality rate and morbidity rate is pretty okay. All right, so the case first example is basically to tell you about the inventory. Now, this is the, as you can see, this is got a distal left main. I'll just go back. And so this is a calcified 111. It's got calcification. This is again from the local perspective. In US, they probably rota it, etc. But here, this is a calcified left rate, real life case. So basically, you've got occluded dominant distal left circumflex, and the late filling shows that the post-occluded vessels are significant size. So the inventory, you need to, the simple wires wouldn't cross, so you needed to have special wires, and then a balloon would not cross that distal occlusion, so you needed to have a 1.25 by 10 millimeter balloon and a good support of the guider. So that's important. So finally, you can change, and then you need to stent that distal bifurcation in the OM, and you needed a trackable stent, as I said, a trackable third generation open cell design DES. Again, once you need a double work, so you need to change it again to the normal workhorse wires, and you needed for the side branch, you need a third generation trackable stent. This is the case why I'm showing you is because the normal stent wouldn't go, and you need a proper size 2.25 or 2.5 trackable thin strut, something like Orzyro or Onyx, to get in. Sometimes the Zeiss would just, Expedition would just not go in here. All right. So then again for the inventory point of view, appropriate size sequential balloons to open up the stent. So 1 millimeter, then 2, then maybe 2.5, and then you could sequentially open it. Sometimes the main branch may not cross with the stent, so you need to open up this the crush type stents, and appropriate size NC balloons for to properly crush the side branch stents. Then appropriate size again deliverable stent, extra long, so that you can save some cost, and then you can pot and recrossing with a hydrophilic wire. Now, in this case, the normal wire would not go, so you needed a hydrophilic wire. So finally, you do a kissing, final kissing for NCs and final plot, and then you can see that the result is acceptable, and you can get, So my aim of showing this case was, look at this inventory. So the inventory shown here it shows you that this is what has been used, and the final, if you can see it, it's around 4,75,000 rupees of just using inventory in Pakistan. So that's a cost that would, in this case, if you can't, so a minimal inventory that's required in these type of cases: polymer coated penetrative wires, you need slippery row profile 1 to 1.25 millimeter balloons in your cath lab, appropriate size NC balloons, thin strut new generation open cell design, drug-eluting stents, appropriate size long deliverable stents to save costs, and rotablative device if that doesn't work, the balloons, and covered stents in case of. So the total device inventory cost in this case was 4,75,000. This excluding the drugs and disposable. This was just what you see on the screen. So the cost, if you don't have the financial base, then you cannot do these cases. Now, this is another case where you can see that we missed quickly. I'll go through. It was simple case. So distal bifurcation, simply two stent strategy, and you can see that the stent was put in and there was a geographical miss, so that needed to be sorted out with a tap. And you can see that now we've got, instead of two stents, we've got three stents in here, and the result is apparently okay. So you've got 2 3 millimeter stents, and so sometimes you need to innovate in these kind of cases. Now this is my final case where there is a modification in left main trifurcation with 58-year-old non-STEMI, LVF of 30-35%, EDP of 25, cabbage diffuse, high-risk complex PCI with an objective of total revascularization. You can see the trifurcation. You can see that this got mid LED, it's got a right is filling up there, and there's a two bifurcations, and the right again has two lesions, TME2 flow, so we don't really know. So complexity in this case is unstable pre-shock patient, culprit for ACS not clear, it's a pan-coronary destabilization as I call it, effective total revascularization is required, all significant vessels of the left main trifurcation need preservation of TME3 flow. So how you do it? First fix the right, simple. Then you do the mid LED for support, and then start with the bifurcation, put a stent into the circumflex. Now you need to crush this. In this case we modified it to crush it with the ramus. So now you've got a little bit of sticking in the left main, but the distal part of the carina angle B is free of stent, and you needed to then do the NC, proper NC, make sure that there's a balloon in the left main, then final kissing, and then you go ahead and put a stent. First you've already stented the distal, make sure that you don't do double stenting of the ostium to occlude the ramus, and so another short stent overlapping distal to the ostium of the LED, and then potting it, 1.5 millimeter balloon initially, and then upgrading the balloons, and to get a final result which is acceptable. So this is a nano crush. So in conclusion, the provisional bifurcation stenting has shown the best long-term outcomes for the moment, but I personally don't believe that. I feel that two stent strategy is more important, more reliable, needs more time, but again, you can use DK crush, Colot, mini crush, and taps in Pakistan. Most commonly used techniques: up front, two front, reverse tap, nano crush can also be used. European operators usually favor Colot for some reason. US and Asian operators prefer DKC, although DK crush needs to be practiced again and again and needs all the steps to be followed. Colot or tap can be used as bailout for major dissection, residual impaired TME3 flow, as I've shown. Choice of technique depends on the coronary anatomy and operator expertise and the comfort of the technique in which he's experienced. The objective, this is very important, the objective is to achieve optimum lesion coverage at bifurcation without leaving uncovered areas and also avoiding excessive double layer of metal at the proximal and distal end of side branch ostia. So final conclusion from the local perspective, complex coronary artery disease is fairly prevalent in our local population, and most people prefer PCI rather than cabbage. A significant proportion of PCIs in Pakistan constitute complex coronary frame, which usually involves a bifurcation. A minimum inventory of special equipment device is required, as I have shown, to effectively do a complex bifurcation. You should not do these cases if there is a financial constraint or if you are not experienced enough. Local interventional cardiologists need to be aware of, trained, and experienced in various techniques and strategies in treating bifurcations effectively and appropriately, and then it becomes a very simple, long-term outcomes are very good. Cost effectiveness of such procedure depends on the patient demographics, financial sponsorships, or personal paying capacity, and most importantly, availability of appropriate technical expertise. And with this, I finish, and thank you very much. And if there are any questions, I'll take it now because I think I won't be able to maintain my non sleep pattern for much long. Thank you.